Hi, everyone. Thanks so much for checking out this preview to our time together on the 12th. I'm really excited to kind of dig into some tools and get some feedback and do some active problem solving together as a group. This sort of lays the foundation for that. So we're going to talk about a model that I designed on the relationship between early childhood adversity and chronic disease later in life. And the goal with the model is to kind of pull together what we know from the literature and then turn that into ways that we can best support our patients. So our first step kind of recognizes the impact of intergenerational trauma or historical trauma, and this can be within families, and it also very much applies to populations and cultures where there's been a lot of adversity in their history, and recognizing the role of that and how that impacts epigenetics. As well as how that impacts attachment and parenting, and how that may increase the risk of exposure to adverse childhood events. In our second phase of the model, we're recognizing the biological mechanisms and the pathway within our biology from childhood trauma to chronic disease. And these can be activated either through intergenerational trauma without the individual actually being exposed to childhood adversity, or through the adversity itself, and recognizing the role of brain development, neural development, neurotransmitters, hormones, and inflammatory systems, and how those can link from adverse childhood events to adult chronic disease. The next phase of the model recognizes those behavioral mechanisms. So the things that people do that can make their health better or that can make their health more challenging. And generally we consider those things to be like alcohol and drug use, nicotine use, risk-taking behaviors, the food, caffeine, and sugar that we consume, as well as physical activity level and how those contribute. And I think what's different about this model than from some others is recognition that people engage in these coping mechanisms or engage in these behavioral mechanisms for a reason. So these drive from coping and a need to cope and manage the adversity that they went through when they were younger. And kind of the recognition that maybe we're trying to dampen sensation because there's a lot of like kind of anxiety or like a lot of activation, and the coping and behavioral mechanisms are about sort of trying to dampen that a little bit. Or maybe someone's been through a history of neglect or things where they didn't get enough stimulation at certain ages. And so their coping mechanisms are then about, and the resulting behaviors about kind of driving up that sensation and kind of heightened sensation seeking. And then our next pathway that this model recognizes, this is psychological mechanisms. And this kind of brings into understanding the role of resiliency, and that, you know, even if someone has a lot of adversity in their life, but there's also a lot of resiliency factors and support and other things in their life that are going well, then those adversities might not have as much of an effect because of the resiliency factors. Whereas if someone has low resiliency, low social support, kind of other challenges in other areas, then that increases the likelihood that this adversity is going to result in disease or in like psychological chronic disease. And also the cognitive schemas of the self tend to be impacted, which is basically just a fancy way of saying that when someone goes through childhood adversity, they often view themselves as kind of not being worthwhile, not being important. They don't have that kind of self-efficacy or kind of ability to change their circumstances because they've been taught that it doesn't matter, as well as kind of their view of themselves in the world and recognizing the role of that. So the psychological mechanisms are posited to impact our behaviors and impact our biology, which then results in increased likelihood of adult chronic disease. Then this kind of piece of the model recognizes that outcomes of disease tend to be worse for people with a history of childhood adversity. So the disease itself is noted to be more severe. Treatments are less likely to work really well. Their overall prognosis is not great. And there's increased likelihood of multimorbidity or more than one chronic disease in our patients that have a history of adversity. And then, of course, all of this occurs within a context. So individuals don't exist outside of their environment. So this recognizes the role of the social determinants of health, and that the interior pieces of the model influence the social determinants of health, and the social determinants of health influence the inputs in the model. So this kind of all together is my conceptualization from the literature, from working with health providers and working with clients on the pathway between adverse childhood events and chronic disease in adulthood. But I think what's been most exciting about this is not like the intellectual pursuit of designing the model, it's what can we do with it. So in my kind of pilot testing of it with clients, a lot of clients give me feedback that this helped them understand what went on for them. So it kind of took some complexity and made it a bit more simple, and then also reduced a lot of stigma for them. So they had a lot of understanding about maybe why they made some of the choices they did, or why some of the things are going on for them, which allowed this to feel a bit more tangible. And then the biggest thing they got excited about was, because there are multiple paths to this, they reasoned that there's also multiple ways to intervene. So chronic disease treatment doesn't just have to be kind of a one size fits all, that maybe we can tailor it to people's unique circumstances and what they're ready for and what's important to them. So through that, we turn this into a worksheet where people could understand kind of their own pathway and their own journey, as well as what that might look like in terms of making things better. So on the 12th, we're going to do some work together on how does this fit your context? How does this fit your population? How might this work in your setting? I really encourage you to like make changes and make tweaks as is appropriate for your patients in your setting. And we'll maybe do some thinking about that. If you feel ready, maybe kind of start playing with it before we can meet. So maybe show it to clients like your patients and get some feedback. Maybe kind of walk through some of this with them, or see if a client sees an area where they might be able to intervene, or where they might be ready to make some change. And maybe think for yourself, where are some places that I feel comfortable and where kind of I think I do a pretty good job already? And where are some maybe places on this model that I could improve my skills or I've had struggle with? And then I'd love for us to talk about that and brainstorm some options together. So the goal for the 12th is for this to be really, really hands-on, really practical. Like, let's actually like get our hands on this and do the work. So if you could come with that mind frame, that would be amazing. And I look forward to doing that with you all. Thank you.